This is CCTA case number 39. The history of that is an 80-year-old man who has some atypical chest pain and an abnormal stress test. He has known coronary disease and indicates that he's been told he's had a 5-way coronary bypass surgery. We do not have the operative report for review. So let's begin by systematically examining this study. Here is the three-dimensional area. We want to look specifically at the sternum to see that this is fully intact. We can then switch to a right lateral by switching to the R view and get an idea that we can see the intact and large right internal mammary artery in its usual place on the chest wall. I can't see any left internal mammary, but we're going to have to get a little bit further into the evaluation. So I'm going to switch to an anterior view and then do some sculpting to try to remove the chest wall and also get a little better three-dimensional view of these bypass. I've done now some rather heavy sculpting of these areas to get a better look at the bypass grafts. I can see now 4 bypass grafts. I can see a saphenous vein that's going to the region of the distal right coronary. I can see a saphenous vein graft coming over to the region of probably the area of the obtuse marginal, though I need to look at this a little more carefully. I see a left internal mammary artery coming down to the area of the left anterior descending, and I see a much smaller graft, much smaller than even the internal mammary graft. This is likely a free radial graft, and it appears to be going to a region probably in the distribution of the first diagonal. But we need to look at this much more carefully, and I'm going to now move over to a two-dimensional view to get a better look. Let's first of all start at the top, getting an idea of the internal mammary graft. This appears to be certainly widely patent. I can see it going down into the distal area of the left anterior descending and reasonably good flow. I do have 3 phases here for review. We can just take a look at the other 2 phases along the way here just to get a better idea, but I think this lima has a pretty good flow. There is some motion artifacts. Let's switch back up to the right view, the foot view, and get a little better look at the other bypass grafts. There is a saphenous vein graft that's coming off right here. I don't really think that that is narrow. Let's take another little look at that. I think that probably is just a normal taper of the vessel and that distribution, although there is a surgical clip right next to it. This area is a bit suspicious if we try to rotate around there. It's not clear. Let's come back to that and see if there's any other issues that we have in this patient. So let's follow this saphenous vein graft. Appears to be coming down. Switch to a foot view here to get a better idea of where it's coming. It appears to be going over to probably a diagonal vessel and then proceeding down into probably the portion of that diagonal. Let's see if we can change the phase a little bit better. But the graph also then takes a point off. It goes here and then tends to go somewhat posteriorly. And you can see that that graph now continues on to what appears to be an obtuse marginal with reasonably good flow. So in fact, this graph goes not only to a diagonal, probably at the D1, but also continues on to the region of the obtuse marginal. Let's switch again, get a little better idea of that, what we thought might be a free radiograph. And this vessel is much more difficult to evaluate. If we look at the origin of this, this is a very small vessel with relatively hazy kind of flow in the area. Let's see if another phase will help a little bit better. But in terms of the anastomosis with the aorta, this is not well seen, so I can't really rule out the possibility that there's a focal stenosis, at least at the origin of this bypass graft from the aorta. The remainder of the graft, we can follow it down, and it appears to be patent. There is some motion artifacts, but this is going into the region of the D2, second diagonal, with reasonably good flow distally. Let's look at the right graft finally. This is coming off here to the side. We can take a better look at this. Let's see if other phases will help a little bit. I think that the origin of this is probably adequate, sufficient. Let's rotate around, follow that graft. Now it becomes much larger as we go down further. There's an area of very dense plaque, actually very dense clip, surgical clip, not plaque. And let's do a little MPR in that area, switch to a different phase. Not easily. You can see here, this is a beam hardening artifact, the very blackness next to the intense whiteness of the surgical clip. Let's go back to a 5mm MIP and continue down. As we proceed down, we can see that the vessel is otherwise patent down into the distal portion of the right coronary artery. Let's switch to a foot view, and we can see the graft coming in here, and then it's going to the PDA. Likewise, the anastomosis with the PDA is not really well seen. Can't really rule out focal narrowing in that region. There is, of course, severe motion artifacts involving the native coronary arteries, which appear to have triple vessel disease. So this is a somewhat inadequate examination, mainly because of motion artifacts. There is a 5-way bypass graft with 4 conduits, so-called 4x5 bypass grafting. However, there were several situations of concern. We can't absolutely rule out any stenosis in the mid portion of the graft to the right coronary, nor its anastomosis with the PDA. We cannot rule out any clear stenosis of significant intent in the area of the takeoff of the free radial graft from the aorta. So we have several areas of concern, and this patient probably would be better served by going directly to coronary angiography and better defining these areas, and the potential for intervention in one or more of these bypass grafts is quite high.